page from your book and go to a shredding machine. Put it in, shred it. Now take it out. Your job, put the pieces back together. Oh, further than that, just like mix it all up. And now you have to put it back together. Not only that, be able to read it and identify what the picture is, assuming you didn't even draw the picture. But I can tell you, a day or two down the line and you try to put it back together, you're going to not even remember what the picture was. And you certainly won't be able to read the written word. The same thing applies when we are dealing with sections from a resection specimen. We sit at our microscope. We are delivered slides, such as this slide 1, showing this little bit of something, and we can see it has purple and brownish areas. Given another little slide of a piece of a larger resection specimen, look at under the scope. Oh, there's this little pink thing down at the corner. And my love is having big resection specimens that aren't fixed well, pulled like taffy, and I can hardly make out any details whatsoever. And our job is to make a diagnosis, of course, a diagnosis that is correct, interpretable, and actionable. Well, you may think, oh, well, sure. Now we have great technology. So what can we do? Let's just put it into our AI machine or grind it up the tissue and put it into molecular and out spits an answer. Well, that's not the way it's going to happen, actually. You put garbage in, you're going to get a garbage answer out. So based on the little slides A, B, and C that I showed you, what's your diagnosis? What's your diagnosis? I doubt you can make one. Well, this is the diagnosis. The diagnosis from those little bits of this larger piece are some very, I think, beautiful purple flowers. I love gardening, for those in the know. This is foxglove digitalis flower. Don't eat it. But anyway, this is the answer. So getting back to the gross room experience, the person presented with this complex recession specimen is at odds. And what we will do today is empower you to be able to simplify the equation and approach things in a logical manner. So let's frame how we're going to do this. Most of the trainees that I deal with when I walk into the gross room and they show the resection specimen to me, their first question is, how many sections should I take? Well, let's see how we're going to approach that question. The first thing is, this is not just a stomach case. I reframe it by saying, this is our patient. We are taking care of our patient. So I reframe the whole conversation. Secondly, I do the following approach. The first is to ask questions. I answer a question with a question. Why was this resected? If we can understand the why, then it follows as to how we will approach it and therefore what we could need to do. So therefore, to the question, how many sections should I take? I answer with a question. And the question is, what are the questions we need to answer? If you can do this and frame your questions, everything else follows. So in order to do that, we have to integrate a lot of information. First thing is to make sure that the resection specimen is in line with the given paperwork provided with a case, i.e., make sure there's no mix-up in specimens. I call this personalized medicine. We then formulate the questions to be answered, and this is had by understanding the clinical history, what the previous pathology reports may say or may not. We need to understand and know the anatomy of the stomach and document both with words and taking photographs of everything we do along the way. And as we approach the specimen, we need to observe, think, and maybe reformulate the questions with which we initially started. As well, we need to understand and embrace that things aren't always black or white, that there is a majority of gray zones in our approaches and the reasoning for what we're doing. And in a lot of cases, there may not be any defined data or reasoning for some of the things that we do. So we need to embrace that and just, again, acknowledge it. So part of approaching this resection is, what is it? What is the lesion? Where is it? Why is it? And is it all out? These are the questions we need to pose and address. We need to understand the anatomy of the stomach. Here's a nice image from Netter. And to take the stomach out, to take the entire stomach out, what has to be done? Well, you need to cut at the esophagus. You need to cut at the duodenum. You need to cut along the lesser omentum. You need to cut along the greater omentum. Why is this important? Because anything you cut in order to get that specimen out represents a margin. A margin is something you cut across to get it out. In addition, we know that the lymph nodes, which are important in terms of staging our tumors, are located as illustrated here. In terms of the omentum, they're not far out in the omentum. They hug, they're in the adipose tissue that hug the gastric wall. So let's now take a look at a cartoon of a proximal gastric resection. What has to be done to get this out? Well, one, the esophagus has to be cut all around because it is embedded in adventitia. The stomach has to be cut out along the omentum that I said. And distally, if it's a partial proximal gastric, then we have a distal cut or more proximal to the stomach, leaving the distal aspect of the stomach intact. So therefore, in terms of that, our margins are proximal, esophageal, distal, that gastric, but then we have a number of radial margins. The entire radial aspect of the esophagus is a margin. And let's not forget the lesser and greater omental margins that were cut to get that part of the resection out. So in real life, what does this look like? Well, here we go. This is a proximal part of the stomach taken out with a longer segment of the esophagus. And I highlight for you the margins, proximal, radial of the esophagus. Those lines represent radial of the lesser and greater omentum. And then the arrow represents the distal gastric margin of this specimen. Now, when we open the specimen up, here's what we see. I show you the junction of the squamous esophageal mucosa juxtaposed to the proximal gastric mucosa. So what is it? And importantly, where is it? Well, the what is it is what we're also trying to address. Yes, maybe there have been prior biopsies to this resection. Hopefully there were, and we should understand what the results of those are. And the where is it is also important. There's no ruler in this image. There should be one, because the documentation of where the center of this is an adenocarcinoma, the center point of that adenocarcinoma relative to the gastroesophageal junction is going to dictate whether we are going to classify this as an esophageal adenocarcinoma or a gastric carcinoma. So the 2 centimeter rule now applies. It used to be 5 centimeters. Who knows, in the future we'll change it. But the point is that the classification is dependent upon that metric. Given this adenocarcinoma, our next question we need to address is, well, what is its stage? How far is it invading into the wall? How are we going to approach that? Well, one approach is to cut up that specimen just like we shredded our paper. It's a 1,000,001 pieces, throw in some pieces and figure it out. Well, that's not logical, and that's going to lead to a lot of issues. Rather, simply just very carefully and thinly section the specimen so that all the sections stay together like pages in a book, and one can therefore carefully look at the inside, so to speak, of each section and determine where your sections would be to reflect the juxtaposition with normal mucosa and the deepest invasion into the wall. Careful attention to the growth in terms of not only looking at it, but feeling it is incredibly important. I demonstrate for you a very small adenocarcinoma of the stomach that you could, yes, you can see, but importantly, by feeling and noting the different textures, you can actually feel. Using my method of just serially sectioning and then looking, you can see here that we have this, definitely this difference in the color of the walls. And you might, given that it's a small lesion, put that entire thing in, which I would definitely suggest. So that's going to be, what is it and how far does it invade into each of the gastric compartments? And additionally, there's another question that we need to address, and that is, why is it? Why did this gastric cancer come about? In order to do that, we need to sample the adjacent and other parts of the gastric mucosa, the non-lesional mucosa. This is absolutely important for us to gain an understanding about on what gastritic or potentially non-gastritic setting did this adenocarcinoma develop. I demonstrated the importance of actually seeing lesions and actually feeling lesions. Here is part of the stomach, and the trainee said, you know, gosh, Beth, look, I found this lesion here. You can see I did your beautiful sectioning here. We can see the wall is bunched up in this area. I'm going to put the whole thing in because, wow, that's the money shot. Well, this is where normal anatomy is really critical to embrace and understand. This is actually the antrum, and we can see on the right, it's the duodenum. And this structure that got the trainee so enthused is normal structure. It's the pyloric sphincter. So understanding what normality is critical in terms of approaching these specimens. And while, yes, a nice section of that would be perfectly appropriate, one doesn't need to put the entire lesion in. So we need to address, what is it? Where is it? And why is it? And the margins, is it all out? So let's take a look at this case. So what is it? Where is it? Why is it? Is it all out? Well, let's take a look at this. We can see on the top that the gastric mucosa seems to be relatively flat. It seems that this lesion does not appear to involve that gastric mucosa. And if you follow the compartments of the wall, it seems to be involving the muscular propria. Do you need to put in a ton of sections to T-stage this tumor? How far is it invading into the wall? Because, you know, well, everything in the stomach must be an adenocarcinoma. Well, the answer, of course, is no. This is a gastrointestinal stromal tumor, and a good evaluation of the growth, I think, would make that basically of 99.9% probability. And the approach, therefore, should be to appropriately documenting and taking sections to grade and establish the margins of this gastrointestinal stromal tumor. So your approach is dictated by the type of lesion with which one is presented. Here's another case, another lesion. We have a nice section, so you can see the wall of this lesion, which is more towards your left, and the more normal aspect of the stomach to your right. And wow, you want to just like put lots of this section in because look, it's clearly invading through the wall. We're going to T-stage this tumor, right? It must be a gastric adenocarcinoma. We're going to get lymph nodes, T-stage it, and, you know, on our way. Well, if you actually would feel this tumor, and this is where texture comes into play in examining these things, it's incredibly soft. And assuming that there's no prior biopsy, which there wasn't in this case, given the texture and given the way that this looks, doing a quick touch prep shows that the most probable diagnosis in this case is a lymphoma. And so therefore, do the appropriate workup for lymphoma, and what does not have to T-stage a lymphoma involving the stomach. So the what is it is going to drive our approach. This is another case that I had a while ago. I show you a simulation of an endoscopic image. And this patient presented, young patient, 27-year-old patient, presented with some abdominal pain. And on endoscopy, the endoscopist showed that there was a little bit enlarged gastric folds. They biopsied the mucosa of the stomach, and I got normal, gastric mucosa. I called the endoscopist. We had a conversation, and he said, well, the person's got these enlarged gastric folds. How could it possibly be normal gastric mucosa, Beth? I said, yes, I'm well aware. I look at every endoscopic image when I do my cases. I completely understand, and I see what you're seeing. So he brought the patient in. He did it again. Got the same answer. We had the same conversation. So at that point, I said, here's what I think might be going on. The mucosa is not hypertrophied. It's not a hypertrophic gastropathy. What I think is going on is something is actually constricting underneath, throwing the gastric folds to mimic a hypertrophic gastropathy. Therefore, I suggest that one gets a deeper biopsy and or has to do some surgical excision to get deeper down to see what is causing this. And indeed, that was done. And the stomach was taken out because it turned out to be gastric, poorly differentiated adenocarcinoma that was relatively leaving the mucosa alone. And you can see on this cut section, you can see the mucosal folds look hypertrophic, but as it permeates through the wall involving the muscularis propria, that it constricts and throws the folds up the stomach to mimic a hypertrophic gastropathy. So correlating what you see is absolutely important, not only resection specimens, but often also when dealing with endoscopically obtained gastric biopsies. Now, in terms of what is it? Well, here is a gastric biopsy that was done. And you can see, wow, there's some infiltrative process that does not look normal. And on higher power, we can see these gastric glands, and in between the glands permeating or something that looks like it should not be there. It does not look inflammatory. And on higher power, these are malignant cells. You can see that. Cytokeratin was done, and you can say, wow, okay, adenocarcinoma involving the stomach is poorly differentiated, do chemo, take the stomach out, be done. Except the astute pathologist doing this put everything together, including history, and this turns out to be Merkel cell carcinoma involving the stomach, and therefore a gastric resection is not needed. So just be very mindful that metastatic tumors to the stomach can exist and can make one go down the tubes and thinking it's a primary gastric cancer, lobular breast cancer being a fine example of that. But here's an example of Merkel cell. So where is it? So here we have a cartoon of a gastric cancer, and it got treated with chemo before it was resected. Now what happens? We are presented with a treated tumor. And I show you the light blue of what is the tumor bed. It looks a little fibrotic grossly. And the dark blue circles are the residual tumor. How are we going to approach this? Well, it may be that we have a lot of tumor left. It may be we have little tumor left, or it may be that there's no tumor left. According to the CAP guidelines, we should put the entire treated tumor bed in. Well, I think if it's a certain size, that's perfectly reasonable. But if it's like 15 centimeters, do we really have to put it all in? Well, maybe. One approach might be, let's just put, every other section and do a mapping. And if we get some tumor and we think that it's representative therein, we could call it a day. That's one approach. However, if there's no tumor in that approach, you're going to end up putting the entire thing in regardless of its dimensions. Similarly, in terms of gastrectomies done for germline mutations in CDH1, and the stomach looks relatively normal, what do? How many sections do you put in? Well, this is the shades of gray area. So at minimum, what I do is put in the entire fat, not the omentum, but the perigastric fat to look for lymph nodes. Some people would say, let's do mapping of the proximal stomach and see if we get cancer or not and go back. So there are a number of approaches that may be done with this. I can tell you for me, what I have done, I have put the entire stomach in. And my reasoning is that I often meet with patients in clinic to go over, because they want to meet with me to go over their pathology. And I can say with complete confidence, this is what I did, and this is what I found. There, again, are other approaches. And again, this is definitely a great area. So here's another gastric resection case. And this one, you can see there are tons of polyps all over the place. This person has GAPS, which is a mutation of the promoter. And so what do you do with this? Do you put the whole stomach in because they have a high risk of cancer? Well, no. I think the logical approach is to just serially section it and then lay your sections out so you can see the relationship of what's going on with those mucosal lesions with the gastric wall. And then maybe put in, representative sections of especially some of those larger polyps. Be mindful of where you've taken them. And if there's cancer, you may want to go back and put in more sections. But certainly I would put in all of the perigastric fat to look for lymph nodes. That being said, there are differing approaches for how one submits lymph nodes in gastrectomy specimens as well. Here's another resection. So yeah, lots and lots of polyps. Are you going to put this entire lesion resection specimen in? Absolutely not. A couple of rep sections here are perfectly appropriate. This is a sleeve gastrectomy. It just happens to have tons of beautiful funded gland polyps. No, the person does not have FAP. And a few reps of these are perfectly appropriate. But looking at the gross of this compared to the previous case I showed you, you can see that there is a profound difference. So understanding the pathophysiology will definitely help you in terms of your approach. Here's another case. We see that, yes, wow, look at the incredible, huge folds in the stomach. So it must be another case of sigmoid carcinoma. Well, no. This actually turned out to be a true case of hypertrophic gastropathy of the parietal cell compartment, ZE syndrome. Do you have to put in the entire stomach? No. A few sections and documenting the disease is perfectly appropriate, but just to highlight this case versus the sigmoid gastric cancer case that I showed you previously. So in summary, what I do is I reframe the question. When the resident asks me how many sections should I take of this stomach, I reframe it. I reframe it of, first of all, this is our patient. Secondly, I say, well, we have to determine what is it, where is it, why is it, and is it all out? And with that, you have now been empowered to find your pathway in a very logical and directive manner.
Thank you, Dr. Furth. That was fantastic. I have warm memories of your grossing lectures from years ago as well. Thank you. Well, we have a few questions from the audience. So first off, from Yara on YouTube, how do you identify the GE junction?
That's a really good question. How does one identify the GE junction? Well, where you have squamous mucosa meeting glandular is one way. However, we know that's not completely effective because of Barrett esophagus. I look at the adventitia, right? So the esophagus has adventitia, the stomach does not. So flip it over and figure it out.
Thank you. Another question from Yaro on Facebook. Do you submit, if it is possible, a vessel tie margin, like as in the left gastric truncus, for example, as one of the radial margins to study its involvement by LVI, PNI, or lymph node mets directly or by low surgical clearance?
Yeah,
That.
so good questions about, dissecting out and figuring out, well, the vascular margin. I mean, the margins are composed of many different things, right? So if the surgeon ties it off specifically and wants to know that specifically, like, go for it. But otherwise, I simply shave the margin and put it in a cassette and call it a day.
Thank you. And then lastly, one last question from Mushaba from Afghanistan. Most of the time, the margin in gastrointestinal organs is folding or shrinking, the muscle layer retraction, and it may show the margin closer than the actual distance, especially in cases which are very close to the tumor. Can you give us any advice on this problem, how to solve it, and how to interpret it microscopically?
Sure. Well, first of all, documenting things fresh is really important. And then when you take your sections, if the tumor appears to be very close to one of your margins, proximal, distal, or radial, then rather than taking a shave margin, I would take perpendicular sections.
Thank you, Dr. Furth. That was fantastic. Thank you for joining us today. And with that, we'll be switching to our next session with Dr. Namraj Satya. So we'll have 1 second and then we'll switch to that. Thank you all.